The model I chose to do was the health belief model. It is a model that was developed in the 1950s by social scientists. It is a psychological health behavior change model that was developed to explain and predict health-related behaviors in humans. It focuses on the attitudes and beliefs of people. The health belief model explores long-term and short-term health behaviors. The health belief model is based on understanding that people will take action if it is health-related. This model was developed due to a failed free tuberculosis health screening program. How it applies to life, there are two components of health-related behaviors. There is the desire to avoid illness or want to get well if already sick, and there is believing that taking action before will prevent or cure any illness. The course of action a person takes depends on his or her perception. There are 6 constructs of the health belief model. The first 4 were developed as original tenets of the model. The last 2 were added for research purposes about how the model had evolved. The first one was perceived susceptibility, a person's perception of the risk of acquiring any illness or disease. It's a person's feelings or vulnerability to any illness or disease. An example would be believing they may have been exposed to an STI or HIV. Number 2 would perceive severity. This refers to a person's feelings on the seriousness of contracting any illness or disease or leaving it untreated. The medical consequences if left untreated, and the social consequences when evaluating the severity. An example would be people believing that the consequences of having HIV or getting pregnant are significant enough to try to avoid. Number 3 was perceived benefits. It's a person's perception of the effectiveness of the actions that are available to reduce the threat or cure an illness or disease. The course of action a person takes to prevent or cure an illness relies on consideration and evaluation. A person would accept recommended health action if they saw it as beneficial. An example would be people believe that the action of getting tested for HIV would benefit them or allow them to get early treatment and prevent infecting other areas. Number 4 was perceived barriers. This refers to a person's feelings on the obstacles required in performing the recommended health action. The person weighs the effectiveness of the action against the thought that it may be expensive, dangerous, time-consuming, unpleasant, or maybe inconvenient for them. So an example would be when people don't want to get tested because they feel as if it is embarrassing or they don't want to be seen at a clinic. Number 5 is cue to action. It's a stimulus needed to trigger our decision-making process in order to accept any recommended health action. The cues can be internal or external, so it could be anything from simple as chest pain to seeing another family member sick. An example may be when kids receive keychains that just give their reminders and messages on it. And number 5, self-efficacy, the level of confidence in his or her ability to successfully perform behavior. This directly relates to whether a person performs a desired behavior. An example would be when youth are confident enough in using condoms correctly in any circumstance. Limitations of the health belief model. The health belief model does not account for a person's attitude, beliefs, or any other individual determinants. The model does not take into account behaviors that are habitual and may inform the decision-making process to accept a recommended action. The model does not account for environmental or economic factors that may prohibit or promote a recommended action. The model does not take into account behaviors that are performed for non-health related reasons. The model assumes that everyone has equal access to the information on the illness or disease. The model assumes that cues to action are prevalent in encouraging people to act, and assumes that health actions are the main goal in the decision-making process. Some key components of the health belief model are gathering information by conducting health need assessments, weighing the consequences of health issues, communicating to the target population and encouraging them, providing assistance demonstrating actions through skill development activities, and providing support that enhances sufficiency and increases likelihood of success. The health belief model has been applied to a broad range of health behaviors in different populations. There are preventive health behaviors, sick role behaviors, and clinic use are the three broad areas. The preventative health behaviors do health promoting and health risk behaviors. Sick role behaviors refer to medical regimes which usually are after someone has been diagnosed with the illness. Clinic use are physician visits for a variety of different reasons. I just put an example of the Michigan model for health, and it was designed for schools. It targeted social and emotional health challenges that occur at school, such as nutrition, physical activity, alcohol, drug use, safety, personal health, and other topics. The health belief model is more descriptive than explanatory, and it does not suggest any strategy for changing health-related actions. And for the most effective use, it should be integrated with other models. And that's it.